What if I told you we can now detect signs of Alzheimer's disease from a blood test before memory loss even begins? For decades, diagnosing dementia required either advanced brain scans or spinal taps. Now, the landscape is changing rapidly, but here's the problem. Most patients and even many physicians don't fully understand what tests are available, what they mean, or when to use them. So today, I'm going to change that by walking you through the blood test that can now detect Alzheimer's pathology years before symptoms start, the brain imaging tools essential to diagnosis, cognitive assessments used in clinical practice, genetic testing and how to think about it the right way, and the reversible causes of cognitive decline most people never hear about. I'm Dr. Kabir Harricharan Singh, and I like to practice medicine that focuses on trying to detect health issues before they become irreversible. Okay, here is a quick, important disclaimer. Though I'm a physician, I'm not your physician. Everything here is educational information only and not personal medical advice. Always talk to your doctor before making any health decisions. Before we get into the test, let me make sure that we're on the same page about what we're actually looking for. When we talk about Alzheimer's disease, there are three things happening in the brain. Amyloid plaque are building up between the neurons, tau neurofibrillary tangles are forming inside neurons, and progressive dying of brain cells, called neurodegeneration. But here's what's critical to understand. These changes begin 15 to 20 years before a single memory problem appears, which means by the time someone walks into the doctor's office struggling to find words, the disease has been building up for at least 2 decades. That's why the entire field is shifting from diagnosis to detection, and that's exactly what these tests are designed to do. Let's start with the most exciting development in this space. Blood-based biomarkers for Alzheimer's disease, which are now available and being used in clinical practice. Here are the main ones. Number 1, plasma amyloid beta ratio. This test measures the ratio of 2 forms of amyloid protein in the blood. A lower ratio means more amyloid is sticking in the brain instead of circulating in the blood. And if you recall, amyloid plaques building up between neurons is one of the changes that happens in Alzheimer's. Now, it's not a perfect test, but it's becoming a useful first-line screening tool, especially for patients with a family history or early memory concerns. Number 2, phosphorylated tau. These are arguably the most exciting markers right now because they correlate directly with tau pathology in the brain. The same tau neurofibrillary tangles we talked about earlier that form inside of neurons. Studies suggest that p-tau217 in particular may be highly specific for Alzheimer's disease, which matters because tau tracks more closely with cognitive decline than amyloid alone. So it not only tells us that the disease process is there, but how active it is. Finally, number 3, neurofilament light chain, also known as NFL. Think of this as the brain's stress signal. When neurons are being damaged, they leak NFL into the bloodstream. So this isn't a specific test for Alzheimer's because it can be elevated in any neurodegenerative condition, but rising levels over time are a red flag that something is happening neurologically. Here's an important caveat. Though these tests are advancing quickly, they must be interpreted in full clinical context. A single number doesn't tell the whole story, and a good clinician ties these results to your symptoms, history, and other findings. Now, before we move on to imaging, I want to address genetic testing, because this is one of the most misunderstood areas in the whole conversation. The most commonly discussed genetic marker is ApoE4, and testing should always come with proper counseling, both before and after, because knowing you carry this variant can be useful, but it needs context because carrying the ApoE4 gene variant increases your risk of Alzheimer's disease, but genes are not your destiny. They inform your strategy. ApoE4 carriers who optimize their metabolic health, manage inflammation, prioritize sleep, and stay physically active can significantly alter their risk trajectory. Even though blood tests are powerful, they don't replace imaging. Here's what's still being used in clinical practice. MRI of the brain is typically the first imaging study ordered, and it lets us look for hippocampal atrophy, which is shrinkage of the brain region that's most critical for memory, white matter changes, which represents damage to nerve fibers that connect different parts of the brain, and it's often caused by poor blood flow or small vessel disease, and lacunar infarcts, which are tiny, deep brain artery blockages that slowly cut off oxygen over time. More than that, MRI is essential for ruling out structural causes of cognitive decline and for understanding the vascular contributions to the picture. The next imaging test is an amyloid PET scan. This specialized imaging test detects amyloid plaque buildup directly in the brain. It's highly sensitive and considered the gold standard for amyloid detection, but it's expensive and often not covered by insurance, but this can change. And finally, the tau PET scan. While the amyloid PET scan tells us if the disease is present, the tau PET scan tells us how far it's progressed by visualizing tau neurofibrillary tangles in the brain, which helps clinicians stage the disease, predict the trajectory of decline, and evaluate treatment response. This is one of the most powerful tools in the specialist toolkit right now. With all these advanced tools available, here's something that's easy to forget. No test replaces actually assessing how someone is thinking and functioning. The gold standard cognitive assessments used in clinical practice include the Montreal Cognitive Assessment, also known as MoCA, formal neuropsychological testing, which is a comprehensive assessment that maps out cognitive strength and weaknesses in detail, and digital cognitive assessments. These tools give us something that blood tests and scans can't, a real-world picture of how the brain is actually performing. Now, before landing on a diagnosis of Alzheimer's or another neurodegenerative disease, it's important to rule out reversible causes of cognitive decline, and there are more of them than most people realize, such as vitamin B12 deficiency, thyroid dysfunction, both overactive and underactive, untreated sleep apnea, depression, which can mimic dementia very closely, insulin resistance, metabolic dysfunction, and chronic systemic inflammation. The good news is that every single one of these is treatable, and every single one of them can produce symptoms that look exactly like cognitive decline. This is why a thorough workup matters, and why jumping straight to an Alzheimer's diagnosis without ruling these out first is a serious clinical mistake. We are living in a genuinely new era of neurology, and for the first time in history, we can look into the biology of a disease decades before it's still someone's memory. That's not a small thing. It's everything. Because dementia doesn't begin with memory loss. It begins with biology, and biology gives us opportunity. If this video gave you something valuable, please subscribe because I'm building a library of contents focused on detecting disease early when it still matters most. And share this with someone in your life who needs to hear it. Okay, I'll see you in the next one.